Great. Shall we get started?
Let's do it.
All right, everybody. Welcome to the second QC Core Insight. We're going to try to build off of the excitement and great conversation we had with our initial kickoff QC Core Insights. This evening, we've got a really engaging and really kind of fun article to discuss. It's going to be, presentation is going to be led by David Krpata, and we're going to follow with the discussion facilitated by Drs. Augenstein and Pauli. So if everyone could just, if you haven't already, go ahead and just mute your microphone, and then we'll get started. And after the presentation, after the discussion, we'll open it up for some discussion amongst everyone in attendance. Again, thanks everyone for being here and look forward to it. David, shall we start?
Sure. I will share my screen. Okay, can you see my slideshow? Yep, perfect. All right, well, first off, thank you for inviting me to talk about this trial. I will say that before I kind of get started into this, I think when I put these slides together, I almost missed what is probably the most important point. And I think it should be the #1 take-home point, and that is that ultimately we were able to complete a 350 patient randomized controlled trial with zero funding by embedding it within the ACHQC. So I just think that, and we'll talk about this a little bit more, but that is probably one of the greatest feats of this trial as well. So with that, I'll get started. So I think most people are pretty familiar with this study by Lewandike from 2000 in New England Journal of Medicine, which really established mesh reinforcement as the gold standard for incisional hernia repair. I think one of the things it also did was it established hernia recurrence as a gold standard for hernia outcomes. And you're probably thinking, well, of course, hernia recurrence is the gold standard. What else would possibly be? Well, there are the other hernia outcomes, and I think some people would argue are maybe equally, if not maybe more important than hernia recurrence itself. And these are some of those patient-reported outcomes, things like chronic pain, which can lead to persistent opioid use. It can lead to increased healthcare resource utilization. What about somebody's abdominal wall function? Is that ultimately more important of an outcome? What about perception of hernia recurrence? Is that better than actually having a hernia recurrence? Or the perception of hernia mesh, concerns that the mesh can stiffen the abdominal wall and decrease somebody's abdominal wall compliance. And a lot of these outcomes have been associated with mesh properties, whether it's construct, material, pore size, and in our case, and maybe most importantly, mesh weight. So as an example, heavyweight polypropylene mesh has been shown to significantly decrease hernia recurrence. That's not a surprise, but it's also been associated with increased risk of long-term complications and specifically rates of chronic pain. So now when you consider that heavyweight polypropylene can be 6 to 10 times the tensile strength of the average abdominal wall, it begs the question, is this somewhat over-engineered, or is this, are we overdoing it with heavyweight mesh? And if we reduce that and try and go to either lightweight or medium weight meshes, will we reduce some of those patient-reported outcomes? So what we're left with is trying to find this balance of the impact of mesh density on hernia outcomes between hernia recurrence, wound morbidity, and patient-reported outcomes. Now, with this in mind, the aim of our study was to investigate the impact of polypropylene mesh on clinical and patient-reported outcomes. But more specifically with the hypothesis that medium weight mesh would improve postoperative pain and quality of life scores with no difference in early clinical outcomes of recurrence rates. So we actually initiated this trial in March of 2017. This was a multi-center trial with 4 different centers. And as I mentioned earlier, it was embedded within the ACHQC. These are the 10 individuals that were involved in this trial. And I think, again, just pointing out that by embedding this within the ACHQC, this is 10 surgeons all entering their own data into the same data source. This study was completed with zero funding. So again, just highlighting the importance of doing this study through something like the ACHQC. So we did, this was only included open retromuscular ventral hernias. We only use polypropylene mesh, and the weight categories included medium weight, which was 40 to 60 grams per meter square, and heavy weight, which was greater than 75 grams per meter square. So when we did these surgeries, again, this was all retromuscular, and the randomization actually occurred after the posterior sheath was closed to try and minimize any bias on how you might manage that defect or impact your overlap, whether or not you would get medium weight or heavy weight. So inclusion, we included only elective cases. These were clean, open, again, retromuscular with defect sizes less than 20 centimeters. Everybody was over the age of 18 in the study, and you were excluded if you could not get the fascia closed during the operation, or if for some reason it was converted to a CDC 2 or 4, which is most common with Mike Rosen and his rates of enterotomies. So our outcomes, primary outcome of interest was related to pain, and this was pain as measured by the NIH PROMIS pain score. So if you use the ACHQC PROs, it's the one that's 3 questions about your pain level in the last 7 days. Secondary outcomes included wound morbidity, 1-year hernia recurrence, and patient-reported outcomes through the HerQLes abdominal wall function assessment. And we also asked patients specifically at the end of the study, do you feel your mesh? And the answer was either yes or no, and they would just circle that on the sheet. So this is the nerdy slide. So this is our sample size estimate. So basically what we did was we used baseline data within the ACHQC of medium weight versus heavyweight cases, and showing a difference of NIH PROMIS scores of 2.8. We based our power calculation off of this. Ultimately, we identified that we would need 320 to show significance, and assuming a 10% loss to follow-up, we estimated an enrollment goal of 356 patients. So ultimately, we enrolled 350 patients, 173 in the heavyweight group, 177 in the medium weight group. And this is our first table of patient demographics. And I think what stands out the most is that these 2 groups are very equal. This is just through randomization. Age, BMI, rates of diabetes are nearly identical between the 2. Recurrent hernias was just over 50% in both groups. In terms of operative demographics, again, patients had pretty equal rates of prior mesh within their abdomen. We had equal rates of transverse abdominis releases performed during these retromuscular repairs, and operative times were similar as well. So our first outcome, the short-term 30-day wound morbidity, our surgical site infection rate for the medium weight group was 6% and heavyweight was 5%. So overall, relatively low rates of surgical site infection, and it was slightly more deep surgical site infections in the medium weight group. 3% in the heavyweight required a procedural intervention, whereas 5% in the medium weight did. More specifically, the wound opening rates in the medium weight was 100%, mostly because in the heavyweight there were some percutaneous drainages. Importantly, there was only 1 partial mesh excision, which occurred in the medium weight group. No patients required complete mesh excision. Other 30-day outcomes, surgical site occurrence rates, again, were similar. Other things like length of stay, reoperation, and readmission rates, also similar between the 2 groups. So getting into the quality of life and our primary outcome, the pain assessment, using the NIH PROMIS 3A score. If you look at these 3 graphs or these 3 bars here, the baseline is on the left, 30 days in the middle, 1 year on the right. And actually our baseline rates were pretty similar. 30 days, they stayed about the same, but there was equal improvement between heavyweight and medium weight at the 1 year. And that was a pretty significant improvement, although no difference actually between mesh types. It's a similar story for the HerQLes evaluation. Again, baseline scores were pretty low. So just to refamiliarize people with HerQLes, a HerQLes score of 0 would be really bad and associate with poor abdominal wall function, whereas a 100 would be perfect abdominal wall function. People are feeling really good about themselves. So obviously here, baseline below 50, people are actually impacted by their hernia. And the good news is that if you look out to 1 year, we're showing a pretty significant improvement in overall HerQLes, which means that as hernia surgeons, we're actually doing a good job here. We're making people's lives better. But it turns out it didn't matter if you used medium weight or heavy weight in this case. Overall, in terms of asking that question to patients, do you feel your mesh after the operation? Maybe somewhat surprisingly, these rates were actually identical, 21% in each group. So hernia recurrence, and I'm going to take a minute to kind of really go through this because this is probably one of the more challenging things, because we ultimately use 3 different modalities to evaluate hernia recurrence. Number 1, physical exam. Number 2, CT scans. And number 3 was hernia recurrence inventory. So this is going to be a busy slide, but as there are 3 different methods in which you can rate hernia recurrence, what we did before we actually initiated our assessment of hernia recurrence is we said, okay, what are the different scenarios that you can have? Meaning, if you look, for example, at the top line, you can have somebody come out positive for a hernia recurrence on the hernia recurrence inventory. They could have a recurrence on the CT scan, and they could have a hernia recurrence on clinical exam. Obviously, that's pretty easy. The consensus definition there is that this is going to be a hernia recurrence. But it gets a little bit trickier when maybe somebody has a positive CT scan, but not a positive clinical exam. So what we did is we actually sent out all these scenarios to the surgeons involved and asked them what their definition would be for each of these. And we worked back and forth with this and came up with this consensus definition. That is the 4th line here. So to complicate things even more, we tried to get the best possible identification of hernias with these 3 sources. And so we did what we call a maximum sensitivity and a maximum specificity evaluation. Essentially saying maximum sensitivity is going to say if there's a modality that's going to identify this as a hernia recurrence, we're going to accept that there may be some false positives, but we're going to overcall this. On the other hand, max specificity is going to say that we really want to have a good idea that if this person has a recurrence, we feel pretty confident that it's actually there. So that's going to be on the other end, we're trying to minimize our false negatives for hernia recurrence. So with that in mind, these are our hernia recurrence 1-year rates. So by modality, physical exam was actually pretty low for both groups, 1% for heavyweight, 2% for medium weight. It goes up much higher with the hernia recurrence inventory. And again, that's people answering the question, do you feel a bulge? And they answer with a yes. So 30% in the heavyweight and 35% in the medium weight. Radiographically with CT scan, it was 3% in each group. So no significant difference between each group, but you do see that there's differences in the modalities and what's being called a recurrence. So then that takes us to our consensus definition, which was agreed upon by all the surgeons involved, with an overall hernia recurrence rate of 8% in the heavyweight and 7% in the medium weight. Again, no statistically significant difference between those 2. If you look for the maximum sensitivity, it's 24% versus 27%. And if you have max specificity, it's pretty low at 2% in each group. So some of our final points here for this study were that number 1, medium weight polypropylene mesh failed to demonstrate a patient perceived or clinical benefit compared to its heavyweight counterpart in the first year after open retromuscular ventral hernia repair. And I think, probably one of the most important points is that based on these findings, our group, and I apologize to Ajita for misspelling our there, our group has changed almost exclusively to heavyweight mesh for clean open retromuscular hernia repairs less than 20 centimeters in size. So with that, open it up to our discussants, and I look forward to any comments and questions.
Yeah, thanks, David. Congrats again on performing a randomized control trial. As everyone knows on this Zoom call, well done. RCTs are few and far between in our space, and so this is really kind of a great advance in what we're able to do for the science of hernia. Well, let's open it up. Why don't we start with Vedra? Would you like to start the discussant, and then we'll head over to Eric, and then open it up to the group here.
David, excellent work. Same thing that Ben said. This is phenomenal work, getting this many surgeons and this many patients to answer this question really takes a lot of work, dedication, and I'm sure this was frustrating at times, but I'm so glad you did it. I really liked your study. I think I have a few questions, just kind of a little bit about methods. And in general, I think one comment, I don't know if you're familiar with the inguinal hernia study that we did in our group that essentially looked at lightweight versus regular weight mesh for the 3D Max. And we essentially concluded the exact same thing with over 1,000 cases. It was not randomized, but it completely confirms that. And we pretty much did the same thing. We got rid of the lightweight mesh and just started using regular weight mesh. So I think it's really important, and we didn't see any issues like surgical site infection, or not surgical, but mesh infection, groin pain, and things like that. So considering that this is, quality of life is a big deal here, I just wanted to ask you about, as far as securing the mesh, some of the ERAS protocol pain blocks, were you able to control any of that stuff and see if it really makes a difference?
Yeah, so first, thanks for the positive comments. So just to kind of echo off of your inguinal hernia study, and I think that's part of the reason why we ask this question is you see a lot in the literature comparing weight meshes, different weight meshes in the inguinal category, but nobody really doing it in the ventral hernia category. So that's part of the background for why we want to do this. So in terms of the way the mesh was fixated, we did require fixation in the protocol through transfascial sutures, and that was done based on surgeon preference in terms of but mostly with monofilament suture. I'm not sure if we actually standardized for whether it was permanent or monofilament. I have to recall. But yeah, we did standardize that. In terms of the pain protocols afterwards, we did not have standardization in terms of the pain protocols, and so people at another institution may have been using something different than at our institution, and that is not something that we specifically accounted for.
David, can I just follow up on that? So the protocol says that you guys used absorbable monofilament, but there was no, at least in the methods, there was no specification about the number of transfascial sutures for fixation. Can you comment? Were there any differences that you're aware of in the number of transfascial sutures in the groups?
Yeah, I'm not aware of any differences in numbers. I will say that, at our institution, we all use typically 8 sutures, 1 cranial, 1 caudal, and then 3 off to each side. Obviously, there was no restriction on mesh size. So if you felt like you had a smaller piece of mesh and you didn't need 8 points of fixation, you were able to do so. So that's part of the reason for not standardizing to 8 specifically.
And I guess the other follow-up to Vedra's question would be, can you look back, since this was embedded in the QC, what blocks patients potentially received? Could you compare the groups in terms of the blocks they may have received to look for any differences?
Yeah, I think, we could have looked at, tap blocks and tried to standardize for that and see if everybody was getting tap blocks or not, because that is within the ACHQC. In terms of, the pain scores at 30 days, I would say that probably, based on some of the stuff we've already done, that's probably not going to make a difference. So I don't know that it's worth it to do that. It would be interesting, is that going to bear out in the 30-day or the 1 year? I'm not sure, but it is something we could potentially look back at.
David, I'm looking for the length of stay. Was it similar in the 2 groups?
Yeah, it was similar between the 2 groups, as well as reoperation rates and readmissions.
And then the other thing is, did you do TARs, or were all TARs done for all of these cases, or were some of them just Reeve Stopa?
Yeah, I can go back to the slide, but it was about 80 to 83% in each group were full TARs, and the remainder were just pure retromuscular stopas.
David, I wanted to ask a question about the differences in the mesh choices between the institutions. And obviously, all politics are local. And so you've got 3 different places performing repairs with 3 different meshes. is there a statistically significant difference between a periatine mesh of 46 grams per meter squared and the Vitamesh heavy at 52 grams per meter squared? You've got two meshes that are, one is in your lighter weight group and one is in your heavyweight group, and they're 6 grams per meter squared different than one another. And so I kind of wonder what the overall weight of the mesh in each group was, and is there a statistically significant difference between the mesh weights between the two groups?
So if I'm following your question correctly, so everything in the medium weight group was between 40 and 60. Anything in the heavyweight was over 75. So I think your question is within the groups, was there a difference between?
Yeah, I mean, you've got, at your Bard facility, you've got a difference of 44 versus 102, right? And at your Atrium facility, you've got a difference of 52 versus 85. And those are, one is 30 grams per meter squared more than the other group. And that's obviously a pretty big difference in the amount of mesh material between the two groups. And so I'm curious as to whether, if you broke this down onto a per site basis, does that difference in the mesh alone account for the evening out of the pain scores between the groups?
Yeah, so good question. We did not specifically average out, based on each individual mesh used and say what was the average weight for the entire heavyweight group, and was there a difference between those who had something that was 100 grams per meter square versus something that was 80. We did not do that. So I think that is a good question, but we did not specifically look at that.
I'm just curious, because if one of your centers put in a lot more patients and they were in the group that's only different by 30, as opposed to the other, that's very different than if the center that put them in and they're different by 60. Those mean very different things, I think, potentially, in terms of the differences between the groups. Just something that I was sort of interested in understanding a little bit better.
Right. And equally as much, we had in our own institution had a change in vendors within the middle of the trial. So we had different weight meshes that we were doing within our own institution for heavyweight and medium weight. So I think in the end it probably averages out, but we did not specifically do that analysis. I think one of the other things we talked about, and I just saw that there was a question that popped up in the chat, and it kind of relates to it. And there is some curiosity that we have in terms of pore size and whether or not pore size might actually impact these outcomes as well. So we've considered doing that analysis, but that is not done specifically for this study.
Coding too, I guess there's a few other variables. So considering this, David, what would you put a midweight mesh in anybody in a ventral hernia repair, or are you obviously changing your practice, but do you think there are any people that are, maybe you would consider putting on it? Yeah,
so that's a great question, because it's really, do you believe in your studies? And I would tell you that, I'm putting in heavyweight in people who are morbidly obese, and I'm doing it based on this data, and I do believe that it's the right thing to do right now. There is one patient population that I still hesitate to put heavyweight mesh in, and that is patients with inflammatory bowel disease. And for whatever reason, I do feel like I want to stick with a lighter weight mesh in those individuals, because there is some concern within the IBD literature and groups that there might be an association with increasing their inflammatory bowel symptoms with placing mesh. So I do, in all fairness, if it's an IBD patient, will lean towards the medium weight mesh.
I'm going to pull the ultimate Mike Rosen maneuver and say the following. I'm going to reconclude your study with the following. You started by saying you started by saying there are two problems. One is that there's concerns that lighter weight mesh will fracture, which is why we sometimes use heavyweight. But the heavyweight mesh leads to a foreign body sensation and more chronic pain, which is why we want to use lightweight. You just concluded that neither of those two things are true. There are not more hernias, and there's also not more chronic pain. And so you made a conclusion based off of negative results for both of those premises that you started the paper with. I wouldn't switch. I would use lightweight. I would use the lighter weight mesh the entire time. I mean, you're not going to get more hernias. Right.
So I would tell you that based anecdotally on our own experience, we are seeing an increase in central mesh fractures from medium weight meshes, which just increases the importance of the durability question, which is why I go almost exclusively to heavyweight mesh now.
So you don't believe the results of your own study then?
Well, so what you're trying to get at, what is 1 year hernia recurrence, is that long enough? And I would tell you that we will follow this out longer, absolutely. But based anecdotally on our own evidence, we're seeing that the data would suggest that maybe not in this 1 year follow-up, but some of our other experience, that the medium weight is fracturing at a higher rate than we would have expected to see.
Awesome. But Mike, before you jump in, hey, I'm one of the moderators, right? Before you jump in. So it's funny, Eric, I actually, when I first saw the results of this, I concluded the exact same thing you did. I'm like, wow, look, everyone can use medium weight. It's fine. And I would say, David, I get it. And, we've all seen those fractures, but here we're talking about your RCT, not necessarily anecdotal evidence. So the data here really says you can go either way with this. And so, you could really conclude that either mesh is adequate.
Well, Ben, to your point, and I mean, I think Eric, listen, that's a very fair, but I think, kind of one of the big things is you have to accept the limitations of what this trial will do. And so we didn't really look at recurrence. We studied it out to 1 year, but I think to answer the recurrence question with this data, you need to go past a year, probably need to go to like 5 years, to be honest, before you can say there's a difference. So, and the other thing is, I think that the rate of mesh fracture with medium weight is unknown right now, but as David said, we do have a lot of experience. I mean, we're, just with the sheer volume of it, I'm going to throw out a wild guess, and I'm going to tell you that I bet it's about 2 to 3%. And the problem is, and Ben knows this, Ben has talked about this, you won't figure that out in a randomized controlled trial with 350 patients. That's something that probably needs to be answered with the ACHQC registry, if we could get more long-term follow-up and kind of get to better definitions. So to answer your question, I think that kind of our conclusion is the reason that we were using medium weight mesh was because we thought that people would feel the heavyweight mesh. These are really large pieces of mesh. And if we were to get an infection, perhaps we could salvage it and all those type of things. And so that's why we were using it. Now that I think we can fairly say, okay, that stuff is off the table. There's no advantage to medium weight mesh in that scenario. I think this trial shows that. So if there's the question of long-term durability, which arguably isn't answered yet, then I think for us, this trial is if there's no short-term advantage, and long-term, the best you can hope for is equivalence in durability. It's unlikely that medium weight will be more durable than heavyweight. So I think that's kind of how we got to that, was because we thought we would see the opposite thing. And when there's no advantage, we're just kind of wondering. But Vedra, I wanted to just add on to something that David said that's important, because there are some situations where we still use medium weight mesh. Number one, currently there's only one large, 50 by 50 piece of mesh. It's a medium weight piece of mesh. So in the scenarios where we need that mesh, we use it. But honestly, after this trial, I wish that somebody would make a 50 by 50 or a 40 by 40 heavyweight, because the fear of putting that in, I kind of don't have it. And we have seen that's some of the fractures. These are disasters to go back on. And two, just importantly, outside of this trial, if you're using something in a contaminated situation, our group still feels like medium weight is what you should be doing.
So Mike, just, based on what you just said then, again, just talking about the data that David presented, wouldn't you expect a reasonable thing based on the data and based on the fact that, a lot of us do use mid-weight mesh in class 2, class 3 wounds? You just err on the side of, something's going to get infected at some point. You'll be able to salvage things. You're kind of on the safer side using mid-weight.
Well, I mean, I mean, we didn't see that here. Like it just, these were 20 centimeter or less hernias. There's 350. Like it just didn't materialize to be that much of a concern about infection kind of in this group. That might be a high volume kind of surgical expertise. It might not be reproducible. I mean, there's a lot of, kind of what ifs for that. But I guess I would push back to Eric and Vedra and maybe some other folks too. If you just step back and say, okay, why do we think medium weight is okay in the first place? Like, how did we ever get down this path?
I'm concerned about infection for sure. I didn't want to start, the kind of derail the conversation, but the follow-up, the length of follow-up, I think you made a good point, Mike, about 5-year follow-up for recurrence, but I think with infection too. And, it's not going to be high, but it'll probably be 1 to 2%, which is what you think the, percentage of recurrence through these midweight meshes. And the problem is that not all of these are different. Some have coating, some don't. And then in the end, I think the trial definitely proves you can do either one. So that's phenomenal. But to really know which one, what's safer, if you have a super thin patient, as Dr. Yunus said in the talk, you use a midweight mesh, inflammatory bowel disease, things like that. Are those meshes able to kind of clear infection better, I guess?
And Mike, I got to that point because you taught me that was correct.
Well, it's really important because, that's why, I was taught this by, Todd Hennifer. I mean, it was when I was a fellow is when kind of all the medium weight mesh, and really it was lightweight mesh at the time, was all the rave. The reality is lightweight mesh didn't really pan out. Like that's pretty much across the board, not been okay. And I, there's not a ton of data out there that also says that heavyweight mesh isn't just fine in contaminant cases. I'm not advocating that, but and I saw Don just said about it might be all pore size. It's difficult for us to figure that stuff out because at the end of the day, I mean, in this trial, there's no difference in anything. I mean, these things literally look exactly the same at baseline, 30 days and 1 year. It's hard to start looking for differences in these things. So again, a lot of this stuff, pore size, weight, all these things, there just hasn't been trials to validate any of these kind of marketing type claims. They're more need to be done in these type of trials. So I don't think this answers all of them, but they're really, I think this whole path of medium weight mesh might, not have been a necessary detour in the improvement of hernia outcomes. I'm struggling with Vedra, as you said, it didn't really pan out in lap inguinals. There's a little question about open inguinals, but for ventrals and inguinals, nothing's really shown it's been better.
David, were you able to look at the certain surgeons? Did you guys randomize the surgeon as well? So for example, your patients, you got almost an equal amount of heavyweight and midweight mesh, or how was it randomized, or did certain people get more of one kind or another?
No, we didn't stratify based off of surgeon. So there is possibility that one surgeon could have had more of one as opposed to another one. That is a possibility.
But I think we randomized based on site. So okay. Each site was kind of blocked up to not have more than one or the other, but no.
So is it mostly Marlex? Was that your heavyweight mesh, or what other ones did you use?
Proline, Marlex, or barred mesh. I gotta pull up this manuscript for the other ones.
And I think it was, what is Alpha uses the Atrium product. I think.
It's ProLite.
ProLite, yep.
ProLite is the heavyweight Atrium.
Yeah.
Which is weird because it has the word light in it.
I know, it's strange. Those are the three. I think those were the majority of the three.
Great. Let's get to some of the chat questions here. Let's see. Andy writes, was similar to Eric's comment about different mesh vendors and different constructions. Let's see. Were there any coated or dual layer meshes? Any visceral coated meshes used, or was it all just bare polypropylene?
It was all bare polypropylene.
Okay. Let's see. Also, a little question about mesh sensation. I thought it was kind of interesting that many people felt the mesh. So what are your thoughts about that, especially kind of in this day and age where, you know, people feel mesh, you know, in their shoe, right? Because there's such a, you know, focus on it. You think it was more a result of that as opposed to actually feeling mesh?
Yeah, you know, I think that, you know, people get, you know, they get an operation and they never kind of lose the fact that they know they had an operation. And about 23% of people will always constantly remember that they had surgery. And if they had a hernia repair, they're going to say, can you feel, you know, can you feel your mesh? Absolutely, I can feel my mesh. I remember my surgery. Whereas some people just kind of get through that and they get back to functioning. And as long as they get back to normal functioning, they feel fine, and it's not a deal for them. But I think it has to do with that.
You know, yeah,
You
it's
think they're
interesting when
supposed
we
to feel the mesh. Like, you feel your mesh? Yep, good. You're good. You can still feel it.
That's good.
It's there.
Exactly.
That's right. You want to feel that. You don't feel it. That's bad, sir. You want to feel it.
That's why the Carolinas Comfort Scale asked that question that way. That's right.
Well, I think it's amazing.
It is
Just
a huge percentage in every study.
I mean, first of all, there's a certain rate of placebo, you know, which is why I think it's always important to kind of have that, you know, other group. Because if you just put a heavyweight trial and you say 20% of people feel heavyweight mesh, that's pretty damning. But I also think the one thing these trials have taught me is it's pretty amazing what people's responses are when you ask them questions. And I would just throw this out there as one thing to discuss as a group that I think it's just a little bit surprising is, you know, after all the hard work that we did and how great we all graded ourselves based on CT scan and physical exam, almost a third of the patients we operate on think they have a bulge at the end of these operations. No matter how great we think we are, a third of the people feel like they still have a bulge. So it's dramatically different than the way we do it and the way we assess ourselves. And I think this one of the things that this trial really kind of was a huge struggle for us is like, you think it's so easy to report recurrence. It's like, yes or no, like, come on guys, this is as easy as it is. But when you really start delving into it, and I see Tom's on the call too, it's overwhelmingly complicated to figure out if in fact somebody has a recurrence or not, which I think is pretty novel. And I don't think that's the way the hernia literature is really written. So Ben, I mean, what do you think about that? A third of the people say they have a bulge. Is that true? Is that not understanding what a bulge means? Are we overinterpreting?
Yeah, actually, let's hold the recurrence discussion until we get through the chat questions, okay? Because I think we're going to dedicate the last half of this discussion just to recurrence alone. So hold that thought. So Jonathan Eunice has a question. From analyzing your own data in terms of patient BMI, do you think possibly super skinny people may not tolerate heavyweight mesh as well as higher BMI patients? So heavyweight mesh in really skinny people.
When do they get hernias? I have never experienced.
If you want to fix that, Eunice, you just need to come up to Cleveland and move out of Florida. That won't be a problem.
Right.
They're the ones that don't have a bulge after surgery because they never started with one.
Well, what do you think? I mean, certainly for England. Oh, go ahead, David.
I think it is an interesting question though, because if you have somebody with a super low BMI, something that you do happen to, you know, that once in a lifetime BMI 20, and you're going to go put in a heavyweight mesh in that individual. I mean, if I'm being honest, I'm probably going to become biased by that patient's BMI, and I'm probably going to go with the medium weight, which I know Mike Rosen is shaking his head because he's like, hey, you just did this study.
Hey, but David,
but you know, there is still, I mean, we still went into this study with the hypothesis that the medium weight was going to show that it outperformed in terms of those patient-reported outcomes. And so I even still have a little bit of that bias in my mind when you go towards those super low BMIs. I know that's not what the data shows. We didn't analyze for something super small, a 20 BMI of 20, but it is an interesting kind of phenomenon.
But I mean, David, you have the BMIs of these patients and the PROs. Couldn't you just plot PRO to the BMI and see what your table looks like?
What we don't have is a patient with a BMI of 20.
Well,
Right.
let me just real quick, because this is really important. Tom, you might want to comment on this, because I think this is where you have to be careful with. We did this big trial, then you start subgrouping and subgrouping and subgrouping, and you really, so I think just my answer to the thin patient is when we look at our data, I think the mean BMI was like in the mid 30s or so. So we probably don't have a ton of lower BMIs just because of the bias of the practice of the people who did the trial. So like, I think it's probably fair to say our trial at the end of the day won't answer the question that you guys are asking. But you know, if you're asking me, I would flip the argument back and say a thin patient needs the strongest abdominal wall possible. So they're getting heavyweight mesh for me, because everybody's going to feel it anyways, and we're putting it retromuscular. But I think that, you know, but Tom, could you just comment on that for just a second? On is that okay for us to go back and do that, or what are the pitfalls if we start doing that stuff?
Well, the pitfall is that if you keep on looking for subgroups, at some point you're going to find a subgroup that has a significant result. That's just the nature of the beast. And that's why when it comes to these subgroup analyses, if you were going to go to the FDA, they would require you to actually pre-specify any subgroup analysis beforehand, just because of this tendency to kind of deceive yourself if you keep on looking at subgroups. But my guess is that this trial doesn't actually have much information at all regarding this particular question.
Yeah, I mean, I think, the hardest thing, and this has kind of been my lesson about all these randomized controlled trials, and probably my greatest frustration is really most randomized controlled trials, when done well, answer one question. That's all you get. Once you start trying to answer 10, just because you spent a lot of time doing it, you're just going down a path. If you want to look at thin people, you should do the next trial, cut the BMI off at 25 and randomize people. Because the other thing I've learned from all these trials, and I was, you know, the first 15 years of my career, we weren't doing this stuff, is that surgeon bias is so hard to control if you don't take it away and randomize people, that you just can't figure this stuff out. Kind of, you know, just with like going back and looking at our different things, because of all that, like, you know, David would prefer to use medium weight mesh. I'd prefer to use heavyweight mesh, and, you know, it's going to be all over the place. So I think it's just, it's endless studies, which is really great for us.
Okay, so moving on in the chat here. Anthony declares to the world, I love heavyweight, but got to say the midweight at our institution is bigger. We talked about that a little bit. Less home plate Prolene sewing. The home plate, or some people called it the pair. And I would worry about the suture line. Can someone design a larger mesh? So Mike, you talked about it a little bit where, you know, so it's kind of almost counterintuitive. So you're saying for the larger hernias that require the 50 by 50, the gigantic midweight mesh, you prefer to use that as opposed to suturing together two pieces of heavyweight polypropylene.
Yeah, I mean, we're getting into like the super anecdotal world here, but so here's the thing. I have sewn a lot of mesh together before we had the 50 by 50. And first of all, the way I sew mesh together is a running Prolene, and then like every 3 centimeters or so, an interrupted Prolene. So you end up with a lot of Prolene knots. And I myself have run into issues with those getting infected, much more so than mesh tends to. As we all know, most mesh infections tend to be a suture abscess that then infects the mesh. So I just won't sew the mesh together anymore. So I will accept a mesh fracture rate over a mesh infection for these really big disastrous ones. And when you're using a 50 by 50, by definition, it's kind of, you know, several standard deviations of a more complicated hernia. So that's my choice. I know there's some mesh companies on. I'm going to be like as blunt as I can be. I hope that this trial gives you the confidence to design larger, heavier weight meshes, so that we have that capability, because I think that is, you know, what I think this trial has shown. And you can still use a 50 by 50 medium weight if, you know, if you feel like the data is equal, and you should use whatever one you want. But these fractures, and we're seeing more and more of them, are really complicated to fix. So I am personally advocating for at least a 40 by 40 or 50 by 50 heavier weight material. I think this trial shows that it's safe to start making those.
David, what do you
So-
think about biosynthetic mesh then, considering this trial?
Yeah.
Where does
so-
it fall? Because you're already using midweights and infected, contaminated and.
Right.
Definitely.
Yeah, I would tell you that I do not typically use much biosynthetic mesh. Personally, I have some concerns about, if we're seeing central mesh fractures in permanent synthetic mesh, what's going to happen when some of these meshes go away? I think that question has yet to be answered. So hopefully, people will look at the long-term data associated with the biosynthetic meshes that are being placed. And I think that that's just one of the most important things is that, if you're going to put it in, make sure you're collecting your data, put it in the ACHQC, and let's see, is this anecdotal thing we're seeing with mesh fractures, is this something that's going to bear out with biosynthetic meshes as well?
But I also think that, Vedra, to answer your question, I think this is prime time now to consider an appropriate randomized controlled trial. I mean, I think we've worked out the kinks of doing it. This is 2 years for 350 patients. I think the reality is a biosynthetic mesh study, though, should have a longer term outcome than 1 year. So I think the 3-year data and where we stand with this is unanswered. I mean, I think we'll follow these people up long term. I was going to ask Vedra and Eric, how many times have you guys seen, everything was fine up to 1 year? I'm not talking about the person who had an infection, complicated drain, and then 2 years later they get a sinus. I'm saying uncomplicated post-op recovery, 30 days look fine. You see him back at a year, CT scan looks good. How many times does somebody come back at 3 to 5 years after that with all of a sudden a mesh infection after retromuscular mesh? Have you guys seen much of that?
Not much. I mean, as far as infection, we've not seen much, but I mean, what in literature we know, it's a percentage for sure. I mean, I don't even know what percentage it is for all of our cases, but I'm sure it's a couple of percent for the mesh infections, the clean cases. I mean, but as far as recurrence, I think you were starting to ask about that too. I mean, certainly patient weight gain has been one of the biggest things. And I worry about heavier weight meshes maybe potentially shrinking more, and coming off the defect. But if they're big meshes, then it should still cover it well, I would think.
Mike, I have not personally seen patients who had completely uncomplicated courses present back later on with mesh infections, either of my own or people that I've inherited. And to your point, I think every single one of my TAR recurrences is related to a mesh fracture. I'm actually doing so. They've all been reduced weight macroporous polypropylene.
So Eric, does that make you want to? So I'm going to rewrite your paper. Do you want to conclude now what David did? Or how many of these is it going to take until you break and you're like, I can't do another mesh fracture?
Well, I've also had a ton of early mesh infections with reduced weight macroporous polypropylene that were all salvaged as a consequence of the reduced weight mesh. So, in a totally clean case, I mean, those were all patients who had some degree of contamination to begin with, but
Totally different. Yeah.
But I've also had some that were clean and came back with MRSA infections and other things that were salvaged. So again, I think if I look at my practice, the meshes that I've salvaged and the meshes that fractured have probably balanced out in terms of the ability to save the reconstruction versus people who've lost their reconstruction at a year. And as you said, I would take the early infection that I can salvage and not result in chronic problems. I mean, I'll take a few delayed mesh fractures to save those meshes.
So can I just ask you a quick question then? Because I think this is where you need the comparison arm. So how many times have you put heavyweight, had an infection, and been unable to salvage it, or is your experience only with medium weight because you're biased by what I told you, and maybe I was wrong?
Yeah. No, I mean
wrong.
Yeah, I mean I rarely use heavyweight mesh. I mean it's an uncommon occurrence. I think the last piece that I used was in a person who was just missing large amounts of their abdominal wall, and I knew it was going to be bridged. And my new partner was like, Mike would put heavyweight in, and I was like, okay, fine. So I did.
Well, I'll be honest with you, and I think David, you should comment on it, because I think this is one of the things that, again, doing these trials have really taught me is when we close the posterior sheath and then we're getting ready to randomize. And there's not a single one of us in this trial who doesn't think that they know what the best mesh for that patient is. And we're all hoping we get the one that we want, and kind of doing these trials where it takes that decision out of your hands. As long as you say hit the button, you get the button. I would say in the beginning of this trial, I was hesitant to put, when you had an obese patient, you're thinking, oh my God, I'm going to get an infection. It's going to involve the mesh. I think this was very difficult. I wouldn't like belittle the emotional angst of giving up the right. I mean, David, would you say, do you have a similar kind of feeling?
Yeah, I mean, there are times when you kind of cringe a little bit and you're like, ooh, is this really going to work out for me or for this patient in the end? And because the decision is out of your hands, and you may be sitting there, like you said, with your bias of like, oh, it would be nice if I got this one. But I think, that's the point of doing these studies is there isn't the data that would support those biases before, but now we have the data that gives us an answer that will, make your decision, help you make that decision. So I think it's important that we do engage in these trials, as long as obviously you don't want to do something that you're going to be putting a patient that you think is actually harmful. That's obviously a different issue. I don't think I ever put myself in that position, but it is important that we answer these questions and we do it in these kind of high level trials. And also, I think it's important that, somebody mentioned in the chat about, is this generalizable to, these are hernia experts that are doing this. And I would say that, it's probably all the more important that, other people get involved in some of these and they have the confidence to do so, because then becomes more generalizable. And you're right. This is a place right now, this study is done at somewhat, centers where there's a high volume of hernia surgery for these more complex surgeries. So is it generalizable? Maybe not completely, but at least it does help us to answer the question for the people who are seeing high volume in this fashion.
Well, can I add on to that? Because I think this is so important, because I think this gets to should this trial change your practice, right? Like that's ultimately everybody kind of has to ask at the end of the day so these 10 people did it. What should I do? And so the reality is, to answer that question, you must know your own data, right? And so the idea of like experts doing clinical trials is kind of a circular argument, because if you have kind of less experienced people on their learning curve, then the trial will be worthless because these things didn't work because these guys don't know what they're doing and they're early on. And then if you have experts, it's kind of the same argument of, well, these are experts, but they don't apply to me. So I think the most large randomized controlled trials tend to be done by high volume centers, because that's just what it takes to get a trial done. And they have the resources and they can get it done. But what it does, what's important is it kind of gets the variability of technique out of the table, and you can dig into these two meshes placed the same way. What does it matter? But for the individuals on this call who are like, should I change or not? The key, and what I would tell each one of you, is this is why you're in the ACHQC. This is actually why you're doing this, because you go to your dashboard and you see what your superficial SSI rate, your deep SSI rate is. If your deep SSI rate is exactly the same as ours, you could probably switch. If it's 3 times what ours is, then I think what Eric and Vedra said is you're probably getting different outcomes, and you might want to look at why that is and how you can improve on that. But these results probably don't pertain to you. So I think you need to know your baseline. Most people don't know their baseline unless you're collecting your own data. So I think that
since my recurrence rate is half yours, I can stay with what I'm doing.
Okay, that's a great question. So the recurrence rate, though, in fairness, and I think this trial, we didn't go heavy on it, and we could talk about recurrence, but I think 1 year recurrence rate isn't kind of the end of the story. I think we all know these things are going to get bigger over time, as all recurrences do. I think when we publish 5-year data on this, I think that will answer the question of, is there a difference in recurrence? And likely it'll be the same. It'll probably be the same, but there's no way that heavyweight will lose. That's my conclusion. But yeah, I mean, if it's the same, it's the same.
Okay. So we're going to get into the recurrence discussion here in a second. There's one more thing we need to cover in the chat. Don Coelho of BD had a question in terms of others reported that mesh pore size matter. We've been talking about weight or density more accurately. David, any comments on does pore size make a difference as opposed to weight or density?
Yeah, again, I kind of mentioned this before. We had an interest in kind of looking at that, but we didn't want to kind of dilute from what our initial aim and hypothesis was. I think it is something worth investigating. Actually looking at the different pore size of each mesh. I don't know that it's actually consistent where you could say that heavyweight ultimately means that the pore size is going to be significantly smaller than some of the medium weight meshes. That's not necessarily consistent. And we need to get all those numbers for pore sizes, and we can potentially do that analysis on pore size alone. But in general, yes, that our data does suggest otherwise. But without looking at the pore size analysis, I wouldn't want to make that statement.
But just to like, the hardest part of this is that these groups look exactly the same across everything. So you need to do the analysis, as David said, but if you just like, you know, there's very little deviation in these groups. This is the results of this operation, regardless of the mesh. So I think we should do that, but then you start getting into subgroups, which we didn't power for and stuff with all those issues. But ultimately, there is no difference. These groups look the same. The mesh probably just doesn't matter that much.
Okay, in the final stretch here, we're going to shift over to recurrence. So I'll ask David. David, can you pull up and share your recurrence slide with everybody? The one where you have the different modalities and the different percentages, and we'll use that to start this discussion here.
Can you see the screen?
Yep.
Yep.
You want this one or?
Yeah, that's the one. That's the one right there.
This one.
Yep. Yep. Okay. So everybody take a look at this for a second and look at the variability in the percentages of the different ways of assessing recurrence. So physical exam, the hernia recurrence inventory, and radiographic, and then composite hernia recurrence, meaning if physical exam or a radiographic recurrence were detected, or the recurrence inventory. And then you see you can ignore the max sensitivity specificity for a second, just kind of those top two there. So I'm kind of curious, it's kind of all over the place, right? So what do people think about this?
Can I start? So I just want to say that every time I look at the hernia recurrence inventory, I curse Ben. I do it all day, and I'm like, why? Why do we have a number that's so different than each other too? And but I think what's important is it kind of gets back to that beginning of looking at patient-reported outcomes, and this is a version of hernia recurrence as seen through the eyes of the patient. So while it doesn't match a CT scan and it doesn't match a physical exam, I mean, if a patient has a bulge, what is the significance of that? And I think there is some significance to it. I think we need to dive a little bit deeper into exactly what that significance means, but I think it is insightful and it is interesting, but I still curse you every time I see it.
Truth hurts, buddy. That's okay. All right, stop sharing for a second. I'm going to show you something here. Okay, to kind of kick off the discussion here. Good. Let me share this.
While Ben's pulling up his screen, I think probably the most important thing to discuss today is the Pittsburgh Steelers just lost to the Washington football team.
All right. So, here's the Lewandike study, right? Okay. So here's the New England Journal of Medicine article pulled up. And there's two things really interesting that never really gets talked about with this study. We always quote the 3-year recurrence rates, 43% without mesh, 24% with mesh, by the way. If you look at the Kaplan-Meier plots here, something really interesting kind of comes up. And this is the thing that really kind of struck my mind when you guys presented your results here. Okay, so if you look at what happens at 12 months in the Kaplan-Meier plots of Lewandijk study, so this is patients without recurrence. The inverse of that would be recurrence. So look at this, right at 12 months, with mesh, it's almost 20%. So it's about 18% or so. I kind of did the calculation here. And then with suture repair, it's, almost 40% or so. So look at that. With mesh at 1 year, it's definitely higher than 10% and probably slightly lower than 20%. So this is like the Bible of hernia mesh. And they're reporting a recurrence anywhere between 15, 18% with mesh at 1 year.
So it would have been
how are yours,
60%. It would have been 60% with your questionnaire.
Well, interesting. Okay. So that questionnaire was actually based out of this article, because if you look over here, this is the second thing that's not really talked about, awareness of recurrences on the part of patients. So this is what led to the development of the hernia recurrence inventory. Basically, when only these self-reported recurrences were counted, the 3-year cumulative rates were 35% for suture repair and 17% for the mesh repair group. So, somewhat comparable here still. Granted, different population, it's done in the Netherlands, different group, but still, this is kind of what we all ascribe to as the gold standard of a randomized trial in this space.
Limited use of imaging to document hernias as well, which is obviously something we don't do currently as well.
Well, I would just respond back to that though, Eric. The reality is for most of our trials now, CT scans are reviewed by 3 blinded reviewers, and we look for a consensus. And again, I have to say this stuff has been shocking to me, but there still is some variability of experienced abdominal wall reconstruction surgeons and what they call as recurrence. It's better than 30%, but all of these things have some background noise to them. And this has been humbling to me. It's really hard to power studies now off of recurrence because everybody's not getting the same modality. It's very difficult to kind of narrow in on like, what is the thing? But Ben, to your point, I think if you're doing a comparison trial, it probably doesn't matter as long as both groups get the same thing. But if you start publishing kind of like one group, and then people start looking at retrospective data, I think that's where we wind up where, people can misinterpret outcomes when we're not using the same definitions. I think that to me is the biggest kind of risk of that difference, understanding that there's a difference in all of those things.
Yeah, I think, that's a key point. And the other thing that I think we've collectively learned, and certainly, this kind of dawned on me a couple of years ago, how difficult it is to assess recurrence. It's really, really hard. Radiographic recurrence, physical exam, we know that kind of breaks down a bit above the BMI of about 32 or 33. Even CT scans, as Mike mentioned, someone's laying supine, a thick sac can sure look like fascia. That's also difficult. Ultrasound is hard. It's very user dependent. The patient reported sensation of a bulge it certainly overcalls it. So even, yes, David, some of your hernias are probably just patients saying they have a bulge. But like Mike said, I think the importance is the relative difference between whatever modality and making sure you have a couple of different comparison groups. So the other thing it might be worth putting out there is, Clayton, you had a question? You had a point?
I do. When we put this together, I actually thought that the table of all the different recurrences, of all the things that might like last on and be referenced, I think that table is actually really important. And do you think, because there's all these different permutations of physical exam, CT findings, patient reported bulge, do you feel like that table, where should that be when folks go to check the box when their follow-up? Because all the surgeons on here are people that probably put data in the QC. So when we do our 1 year, 2 year, 3 year follow-up, should that be the gold standard of what a QC designated recurrence is?
Oh, you mean kind of that matrix created?
Yeah, yeah.
Yeah, no offense to Tom and the study group. I hate that matrix. I see that and it just makes my head spin.
So how do you reconcile, I mean, so, there's certainly times when you think there's not a recurrence, you look at the CT and you're like, uh-oh. Or there's other time where you look at the CT and you're worried, but you walk in and they don't feel a bulge and the exam feels normal. So what do you do?
Yeah, so I think, I mean, you might, as a single surgeon, right, find different results for the different modalities, right? I think ultimately it really goes back to what's happening with the patient and their quality of life. Two common scenarios. Someone had a, 20 centimeter transverse with multiply recurrent incisional hernia 3 years ago. They had poor quality of life. You see them 3-year follow-up, they have a small recurrence. No question it's a recurrence, but they feel much better. They're okay. I think that's still a success, even though that it's a recurrence. Contrast that with someone who had a 1 centimeter umbilical hernia. They get a recurrence a couple of years later, acute incarceration, take them to the OR. Yeah, it's more of a, issue. And so that's where I think, we think way too, honestly, my conclusion about studying recurrence for the past 12 years is we think way too simplistically about recurrence. We try to force it. Go ahead.
Well, that's a different argument. You're arguing whether recurrence is the most important thing. I'm not arguing that. You may be right. Quality of life may be more important. But at the end of the day, we have to decide what is a recurrence and what is not. And the box is yes or no. And, the important thing of determining, just for something as simple as determining the durability of meshes, that.
I got you. No, I hear. Yeah. So I think there are different types of recurrences. There's patient-reported outcome recurrence, there's radiographic recurrence, there's clinical recurrence. And you're probably going to get different answers for those different modalities. And I think we just report all of them. I think trying to make a single one recurrence that rules them all kind of thing is just not practical. And also because everyone has different methods available to them to assess recurrence. But I also think, I'm going to go back again, sound like a broken record. I just don't think we can think of recurrence in a vacuum as a binary thing. It's got to be combined with quality of life, and it's got to be kind of combined with kind of the context of what you're assessing the patient with.
So Ben, you're arguing that in the absence of fascial defect, that a patient-reported outcome of a bulge should, in some circumstances, be considered a recurrent hernia.
Yeah, and I'll say it for 2 reasons. Number one, it's a patient-reported outcome recurrence if we kind of stick strict to that modality, right?
But it's not a hernia by definition.
Well, hold on a second. So how do you know it's not a hernia?
Well, I'm telling you, I stuck a laparoscope in. I've got a CAT scan. There's nothing on physical examination. There's denervation there. The patient says this is a bulge. You're saying that should go into this is a hernia category. I mean, I meet lots of folks. I meet folks who have bulges in my clinic that aren't hernias and I don't operate.
I got you. Again, look, we're going to have this argument for 2 hours, right? How do you not know that there's thinning of the fascia such that it's going to become a hernia that would by any means be classified as a hernia, but it's a bulge?
But the definition of a hernia requires sort of documentation of a fascial defect.
So I would actually argue that, no, there's no question about that, but there's a spectrum going from a closed fascial apposition all the way to a hole. We're thinking of it too simplistically as just binary because the thing just separates over time and weakens that fascial opening. It's not that simple.
So a diastasis then is a hernia?
Post-op though, Eric, not, this would be, we're not talking about a de novo abdomen, right? We're talking
well, right,
about,
but I mean, how do you have a different definition for what a hernia is in a patient who's had a surgery versus who hasn't had a surgery?
Well, I don't
right,
think that HRI is for people who haven't had surgery though, right, Ben? I mean, this is for.
That's correct.
Well, yeah. Right, but the definition of a hernia has to be standardized in all patients, right? I mean, like, there is a standard definition of what a hernia is, and it requires a defect in a myofascial layer of the abdominal wall.
So, look, that's exactly what I'm saying, is that we're thinking of it way too simplistically. We're forcing it into simplicity when there really probably shouldn't be any. I mean, how do you know when you get that CT scan or when you examine that patient that you're not along that spectrum between closed fascia to frank hole, and you just happen to catch them when they're thinning out? You don't know.
I don't know that, but I also wouldn't rely on the patient outcome, like the patient's definition, to say that there is a hernia.
Well, but hold on just a second, Eric. Don't you think if you get, so one of the problems with hernias is like recurrences, that we kind of take that personally as like a technical failure of this operation, not or very dissimilar to like the biology of cancer. When somebody recurs with cancer, most people don't kind of own that they're a bad cancer doc, oncologist, whatever. So I think there's a lot of kind of secondary issues with when we say somebody has a recurrence. But if you kind of move away from recurrence as a technical failure, and you just say, it is somewhat fascinating that this trial, which I don't know if David mentioned this, but we had 90% 1-year follow-up. So that's, 330 or 25 people or so with all the same. And interestingly enough, if you move away from all the stuff about it, a third of the people that we operate on feel like they have a bulge after this operation. That is somewhat surprising to me. What, aside from recurrence or whatnot, I think this is like a rabbit hole we'll go down for the next 10 days. But they report, when you ask them, do you have a bulge? They say yes. And to me, that was a little bit shocking, and was kind of eye-opening of like, is there somewhere we need to go next? Do we need to remove more skin? Do we need to worry about contour? We need to link up whether those bulges are affecting people's, HerQLes score and their quality of life and all those type of things. I think there's a lot more where we have to go down this path, but it is.
I have no problem going down those paths. I just think that saying that all bulges reported by patients post-op should be counted in a hernia category in the absence of any other exam finding is the wrong way to go.
Well, but then what do you do with the patient, which is common? Wait, hold on. Let me just ask him back this. What do you do with the patient that is common? How do we handle the patient that just has the hernia recurrence inventory questions filled out and there is no physical exam or CT scan, which is very common?
I mean, bulge without evidence of hernia.
PRO recurrence.
But I think it's important to also point out, I mean, if you were to offer across the board hernia repairs to patients that would then presumably get up to a 30% chance of a bulge after surgery, do you not think that might change their paradigm on getting the operation to begin with? I mean, I think the relevance of it is that for whatever reason, they feel a bulge and they're not satisfied, right? So like the kind of what that counts as is, I think, not to be.
Yeah, and I hate to break it to everybody, but here's the 10-year follow-up of Lewandite's data. And the longer you wait, the more chances we have of recurrence. And look at that with mesh repair. Yeah, it's still pretty high, onwards of about 30%. So I think, again, it's just going back to this. This is far more complex than we like to make it. Eric, certainly the patient-reported outcomes of determining hernia recurrence probably overcalls it. There's no denying that. But we have developed a body of evidence to say that, yeah, it's actually not a bad surrogate measure of recurrence when you don't have anything otherwise available to you. Is it perfect? No, hold on a second. It's not perfect, but it can be used to determine relative differences amongst a similar population.
Were there patients who actually had hernias, but their reported outcome was that they didn't? Did you have any in that group where they just didn't notice they had a hernia?
Yeah, there were a few. Again, it wasn't perfect. There were a few both ways, and we compared this with CT and compared it also with ultrasound. But in general, if you look at actually just the bulge question, we initially developed the hernia recurrence inventory, also incorporating do you feel that your hernia has come back? And that's actually what Lewandike did, is they asked patients just that, do you feel like you had a recurrence? The problem we found with that was people confused pain with the recurrence. And so because then we found out we doled out a lot of chronic pain with these patients. So again, it's super complex.
Hey, Ben.
Who's to say pain is not a recurrence?
Well,
Yeah.
so just to not get too much in the weeds on this, even though we're already there, but it's important in the study, if you take it back to that we presented all three. And if you look at the composite that was agreed upon by the surgeons beforehand, not every positive response on a hernia recurrence inventory was deemed a composite recurrence. But I think it's important for transfer to get a sense of what these patients are feeling as an outcome. And maybe it's not a physical fascial defect, but is there a mental recurrence that impacts this patient? And that is, I think, to Ben's point, is what the importance of the hernia recurrence inventory. And I think we need to look further into hernia recurrence inventory association with HerQLes, and how does that, what does that bulge mean for abdominal wall function and patient perception?
I think this is a lot of Bruce Ramshaw's work and interest, because he has a lot of these people go into like cognitive training and things like that. A lot of these patients are morbidly obese. They're going to have a bulge when you fix their hernia, just what their belly looks like, even though it's not a hernia. So I think, maybe 30% of them needed to be in cognitive training so they can have realistic expectations that they're not going to look like a supermodel,
This is not a hernia. That's how we do cognitive training in Cleveland. Suck it up.
Did Krpata just coin the term a mental hernia?
You don't have a hernia. You suck it up. Don't look at that.
It's a mental hernia.
I'm coining the term mental hernia.
That's it. Wait, listen, because we're running out of time. Can I just, for the sake of the kind of one of the things I think, and again, we do this a lot in Cleveland, but I think it is really important, is to see how these type of things impact people's practice. So can we take 30 seconds here, and everybody, we're not going to judge anybody, but everybody bounce your videos up real quick. And I'm going to ask you, I'll give everybody a second to turn your videos on. Raise your hand if this study is going to change your practice and either use more heavyweight mesh, go exclusively to heavyweight mesh. Will this change your practice in any way? So if it will change your practice, raise your hand. We got a lot of yeses. All right.
Wow.
All right. That's a lot of yeses.
Impressed.
All right, Ben, take away.
That's cool. Wow. Well, folks, it's getting a little late. That was an awesome discussion, and I want to thank David for presenting incredible work, and also to he and his partners for launching another RCT. That was fantastic. Vedra and Eric, thank you for the discussion. That was really, really educational, and I think really highlighted some of the things that we think things are pretty straightforward, but they're certainly not. And that was a fun conversation. I would also like to mention that on this Zoom, in addition to all the surgeons we have here, several of you, we have our analysts here. It's really nice to be able to have input from them in this type of forum, and also several members of our QC team. And we have some members of industry as well. And so I think that really highlights and shows, what this collaborative is. It's not just surgeons, it's all different types of folks involved in the care of our patients. So thanks, everybody. It was really a lot of fun. This is our second QC Core Insights. We look forward to the next one. Hope everyone has a fantastic holiday as much as you can in the current times. And we look forward to the next one. Thank you. Have a good night.